In modern immunotherapy, we all know that managing toxicity is just as critical as achieving efficacy. But what if we could move beyond just reacting to side effects? Today, we're going to dive into the art of proactive toxicity management. It's about fine-tuning the immune response, making our most powerful agents not only safer, but a whole lot smarter.
All right, here's our game plan. We'll kick things off with the core challenge of immunotherapy toxicity. Then, we'll break down two key strategies: how to tame the infusion-related reaction storm, and how to get ahead of the cytokine release syndrome threat. From there, we'll tackle the triple therapy question and wrap up by looking at where this is all headed.
So the central challenge here is really the classic double-edged sword, isn't it? We've got these incredible agents like bispecific antibodies that offer unprecedented efficacy, but that power comes with the very real risk of severe toxicities. We're talking specifically about infusion-related reactions, or IRR, and of course, cytokine release syndrome, CRS. Mastering this balance is absolutely fundamental to clinical success.
Okay, first up, let's look at how we can proactively manage IIR. The combination of the BTK inhibitor Ibrutinib with the anti-CD20 antibody Obinutuzumab gives us a brilliant example of a preemptive strategy in action.
And the data here is just striking. Take a look. Analysis from the Illuminate study shows that Obinutuzumab by itself comes with a 20% incidence of severe, grade 3 or higher IRR. 20%. But simply by adding Ibrutinib to the mix, that incidence just plummets to 3%. This isn't just a statistical improvement. For our patients, it's a clinically transformative reduction in severe toxicity.
So you're probably wondering, how does this actually work? Well, Obinutuzumab can trigger this massive release of inflammatory cytokines, and that's what causes the IRR. Ibrutinib, by inhibiting BTK, basically acts as a cytokine buffer. It preemptively blocks the downstream signaling that leads to this cytokine release, effectively calming the storm before it even gets started.
Now let's pivot to a different, but very much related challenge: cytokine release syndrome with bispecific antibodies. And here we see another really elegant protocol, this one using Obinutuzumab as a pretreatment before we administer the CD20 x CD3 bispecific Glofitamab.
This protocol is really the cornerstone of managing Glofitamab safely. And notice the timing, it's everything. A full 1,000 milligram dose of Obinutuzumab is given on day 1. That's a full week before the first tiny step-up dose of Glofitamab. This schedule is a deliberate and absolutely critical strategy designed to prepare the immunological environment for that T-cell engagement.
So what's the logic? You can think of it as a preemptive strike. Glofitamab's job is to link a T-cell to a cancerous B-cell. But if there are too many B-cells present all at once, the T-cell activation can become overwhelming, leading to severe CRS. By using Obinutuzumab first, we debulk or deplete those peripheral B-cells. This reduces the number of targets and ensures a much more controlled, manageable T-cell response later on.
And the clinical data absolutely validates this approach. In the pivotal NP3179 study, this protocol resulted in a really manageable CRS profile. Now, while around 63% of patients had some CRS, the vast majority was low-grade. And crucially, the rate of severe, grade 3 or higher CRS was kept below 4%, which really demonstrates that this is a highly effective mitigation strategy.
So this brings us to a logical question that a lot of clinicians ask. If the Ibrutinib-Obinutuzumab pair works for IRR, and the Obinutuzumab-Glofitamab pair works for CRS, why don't we just use all three together for maximum protection? It's an excellent question, and it has a few very practical answers.
Well, the most fundamental reason is that these protocols are standards of care for two entirely different diseases. The Ibrutinib-Obinutuzumab pairing is a frontline therapy for CLL. The Glofitamab protocol, on the other hand, is for relapse/refractory DLBCL. We're talking about an indolent disease versus a highly aggressive lymphoma. The clinical contexts are just completely different.
And beyond the separate indications, there are other pragmatic clinical reasons. First, the Obinutuzumab pretreatment is already so effective in mitigating CRS that adding Ibrutinib would likely just be redundant. Plus, Ibrutinib isn't benign. It carries its own toxicity profile, including those risks of atrial fibrillation and bleeding. And without clear evidence of benefit from large-scale trials, which we just don't have, adding that toxicity is really unjustifiable.
Okay, let's move into our final section and look at how this thinking is evolving.
because the conversation is really shifting from using these combinations purely for safety towards using them to achieve true therapeutic synergy.
This quote just perfectly captures where the field is headed. This is no longer about simply stacking drugs on top of each other. It's about leveraging a deep mechanistic understanding to precisely modulate and fine-tune the immune response for the best possible outcomes.
And this is where it gets truly exciting. The next frontier isn't just about reducing toxicity, but about actively enhancing efficacy. We're seeing fascinating data from the CAR-T space, like in sub-studies of the ZUMA-1 trial, suggesting that BTK inhibitors may do more than just lower CRS. They might actually improve T-cell function and persistence. And that, of course, opens up a whole new paradigm for research in bispecifics as well.
So this leaves us with a final crucial question. As our paradigm shifts from just managing toxicity to actively enhancing efficacy, what new synergistic combinations are going to emerge? Mastering the immune system remains our greatest challenge, but it's also our greatest opportunity. Thanks for joining this explainer.